On behalf of the Academy of Osseointegration and the Dental Guys podcast, I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. Here we are, day 2.
Yes.
And an exciting day 1. We saw everything from, some awesome lectures to, at the end, some fireworks.
Yeah,
right?
If you haven't had an opportunity, you can go back and watch the discussion with Dennis Tarnow, Howard Gluckman.
Mm-hmm.
Also, we brought on Bach Lee to talk ridge augmentation. And then we also had a heated debate between two friends, right? Dr. Norton and Dr. Testori, talking about ISQ versus insertional torque value. What's valid? Where do we go from here? And the collaboration really between those two things, I think, John, was great. Heated debate.
Yep.
Those two people are high level. And, if let me just say this, as far as like where you need to go to listen for this type of content in the future. If you're a podcast fan, you need to head over to the Dental Guys podcast, and we will be re-releasing these in a different format, an audio format. So if you're like wondering, how do I get this content to my phone? Subscribe on Apple Podcasts or anywhere you get your podcast. That can be on Spotify, any podcatcher will get that. Follow us there on those outlets, as well as following today at the Academy of Osseointegration Facebook page. You can hit us up on Twitter, hashtag AODentalGuys22. Send us your questions right there. If you have questions for any of our speakers, if they're not on, even then, we can ask those questions to those speakers later, or maybe John and I can entertain those. But who do we have today, John?
Yeah, well, we're kicking off the day strong. That's what we wanted to make sure we would do. And one of my good friends, and one of my oldest friends in dentistry, really, that I've known ever since dental school, Dr. Mark Ludlow, is here with us today. Mark, good to have you.
Yeah, hey, thanks to be here.
Friend of the podcast,
yeah,
too, right?
That's right.
Done this a few times with you guys. It's always fun. I mean, it's funny. The podcast ends and we end up like chatting for hours after. We stop rolling.
Yeah, the post-podcast show could have been another show usually when we've done that.
Show.
But it's been cool to watch as and we'll let you talk a little bit about what you do. But I've gotten to see as your career has kind of moved and progressed, and you've gone from back in the dental school days to now being on the main podium at AO. Tell us a little bit about the last couple of years, because there's been some cool changes happening. Tell us what you're doing now, what you teach, that kind of thing.
Sure. Yeah. So we actually did make a big, huge move. We talked a little bit about it on your last one, but made the move back to Utah. So I'm from Utah originally, moved back there, became part of the University of Utah, and that's been a really fun thing, being back home again. Plus, the school is very progressive, so we've been able to implement a lot of really cool things that, in an easy way. We switched to all complete digital dentures. We do about 500 arches a year, and 100% of those are manufactured, in the actual school and whatnot, and printed and whatnot. So there's a ton of really cool stuff that we're doing. I mean, digital all over the place. It's been a fun journey so far, to be honest.
Yeah.
So.
And you're getting to work with also the dental students as well as some graduate students as well. Is it kind of both?
Yeah, it's a little bit of both. Right now, our graduate programs, we've just got a GPR program.
Okay.
So we've just got a little interaction with those guys. But for the most part, it's with the students. And then our plan is we're going to be bringing on oral surgery and pros over the next little bit and get those.
That's awesome.
Those residencies
It's exciting
going.
times at the University of Utah.
Yeah, it's fun.
Yeah.
And I mean, I grew up 10 minutes away from the University of Utah. I grew up a lifelong Utah fan, much to my wife's dismay, because she's a BYU fan. So I mean, there's a lot of like hatred in the home all the time due to that. But yeah, it's good.
You're building a curriculum that really is starting from the foundation of digital.
Yes.
And we know that as the Academy talks about, they really brought a pros perspective to surgical perspective and how these two interact, and restoratively driving the implant placement. But then the idea that we can now go a little bit further, 3D guided surgery. Now we're talking about placing implants through the guide, depth, angle, all of it, everything. Yeah. Talk a little bit about what's in your wheelhouse right now, what you're trying to build as far as this digital dentistry era.
Yeah, so I think we're all trying to kind of get to that holy grail of where everything's pre-manufactured, all the parts are made beforehand, and you just go and it's just, basically putting Legos together back in the patient's mouth. And I think that's where we're all trying to go with things. There are a couple little issues with that. We've basically nailed it from the single tooth perspective. Like, we've got that dialed, and we've been doing that for a long time to where we can have the pre-made custom abutment, the pre-made provisional. We can use that same file and just hit another button and go ahead and make the final crown from it. And from the single side, like, that's not been a problem at all. Where it comes a little bit more difficult is the full arch, because now you've got a lot of different fixtures that are needing to be so precise so that all those parts fit absolutely perfectly in there. And that's where some of the challenges can be a little bit of just the timing, because now you've got to time, 6 implants absolutely perfect at the exact right depth. And what you can't really account for is, when you go into the osteotomy with your implant, it's spinning. You can't time exactly when that's going to bite the bone and start going down.
Right.
So there will always be this little tiny bit of slop factor, and depending on how much one full rotation of your implant is, there will always be kind of bigger or smaller slop factors due to that, depending upon what that turn is.
So what you're saying is the incisal edge position could change apically or coronally depending on when it bites. And so that's an interesting thing about guided surgery. It's accurate, but it's only accurate as far as like some of the technology that we have available.
Because you still have the biology that you're dealing with that you can't say, oh, well, it's in the perfect prosthetic position, but I'm only at 2 newtons.
Right.
So there's
or
still.
can you?
Or can you? Right. We might need to bring Norton back on, right? Yeah. So I want to talk first, just while we're in the single unit world, because we definitely want to talk about full arch and some of the technology actually behind the scenes with software and hardware. But one of the things we've talked about in the past is, what steps can you eliminate, right? The idea with digital, at least the thought process is pre-planning so you can eliminate potentially steps that you used to have to do in the analog world, or going back and forth from digital to analog, which is where we know a lot of our problems show up. One of those areas that I think for years we've still done in the analog world has been, once you've developed your tissue, implants placed, tissue development's done, you've got this beautiful provisional, and now you have to copy that into the final.
Right.
Now, assuming that you didn't, have everything perfect in your original provisional, so you had to add to it, you had to change it, which is very common. We always used to have to make customized impression copings. We would have to translate that information to the lab. So we were going out of digital or from analog back, and we had to go back and forth. But I remember a couple of years ago, we started to see some proof of concept papers on this being able to be done digitally, where we could take a provisional, we could scan it, because it was always a challenge, right? If you took the provisional off, tissue wanted to collapse. So is that a step or a technique that is available to the masses now to be able to copy a provisional and then merge that back in? And tell us a little bit about how that would work.
Yeah. So, we're funny as dentists. Like, we just get into these routines and we do the same thing because that's what we've always done. And a lot of times we end up duplicating a lot of our own work. And that's one thing, if you spend all this time building a provisional, and again, we spent a lot of time looking at this, looking at what the responses of the tissue, because if you look in the literature, all this, you talk about, you say, you pull off the provisional, the healing abutment, we all go, because the tissue collapses, but we don't even know really the rate at which it collapses. And so we've actually we were working on a master's thesis right before I left relative to that, because we figured out a way to actually quantify it. And it was that scientific principle came from our clinical understanding of how we could copy contour. Okay. And it's very interesting because when you look at it, just by taking it off, you lose almost a millimeter in about 45 seconds to a minute.
Wow.
Okay.
Wow.
And again, we don't know if we haven't done enough of it to say, well, is it, thick biotype, thin biotype, what's the difference, all these different things. So we've got a lot more to go relative to that. But we all know it collapses, and we know it collapses pretty significantly. So how can we capture that?
Yeah.
So I think the best way that we can is there's 2 different ways, and it really just depends on how you built your provisional. I do a lot of my provisionals with some workflows, with Dentsply Sirona and some other companies, to be able to have a pre-op, pre-surgical custom abutment made.
Yes.
And then the provisional crowns directly on top. Now, the workflow always is, okay, you got this sweet thing. Now you got to take this all off, put a scan body in, scan that, and in that instance, the tissue's collapsed and you're done. So one of the workflows with that is I just pop off the provisional crown and keep the actual custom abutment there. I'll scan that and take an abutment level scan. And it's not, you don't have to pat cord, you don't have to do anything, because one of the file types when you get this is what's called a core file. And that's got all your margins. That's basically a die of your abutment. And so all I've got to do is scan the top of the abutment, then I can go in digitally and merge back that die of that core file, if you will. Then I've got my perfect marginal, integrity there, and I can build the crown off that way.
Gotcha.
So if we're going that pathway, that's how you do it, and that's the easiest way to do it. If you're doing a conventional, provisional, where you've got a temporary abutment, you've, put
chair side,
the composite all around, and
Mhm.
you've spent all this time sculpting the tissue. What we do on that, and this is just all it takes is one extra scan. So you do all your pathway like you normally would, scan the provisional in the mouth, take it off, scan the soft tissue, and try to get it before it collapses. Put the scan buddy in and scan that. And that's usually where we stop. Okay. But once you finish that, just close that, open up a new case on your scanner, and take that great provisional that you've spent, years building this stuff all out of, throw it on an analog, scan your provisional, scan the surface that's going down into the tissue, and scan it down onto the analog. Because from the laboratory side, what we're able to do is we're able to take that tooth, merge it back with the provisional in the mouth, and now we've got those exact contours that you spent all that time building. And then from there, the lab can see that all in cross-section, and they can build out your abutment.
So they're using the analog
everything.
as the commonality. Is that right?
Well,
in
actually,
the
he
merge?
scanned
you're
the
using
provisional.
You're actually the provisional,
It's-
like the facial surface of
Yes.
the provisional,
Yeah,
for
because
instance.
you're scanning that because you want to give the lab the provisional anyway, okay, so that they know where to build your tooth. And what you're doing is that you're scanning the provisional in your hand, and you're just merging the tooth to the tooth that's in that provisional scan in the arch.
So one extra scan.
It's one extra scan,
And
it
you
gives
save
you
all
all
of
of that.
Yeah, I think one of the things that you and I've talked about is putting our prosthetics back on master models. And one of the things that we've done is that when you have full arch prosthetics, especially if you're doing, any type of, milled PMMA product, and you've worked, tirelessly working out function and aesthetics, but you don't want to pull that away from the patient and actually take their temporary away, right? Because they're in that, and you don't want to go back to the surgical provisional. And so,
No way, those things look so good always.
That's right.
So,
but this idea of taking it back to the model, and actually scanning it, and then being able to merge it back in software with an in situ scan, which is in the mouth, I think is pretty key. And so I'm excited to hear that we have some workflows. A lot of this stuff is done in software, right? Is this teachable?
Oh yeah,
right.
I mean, sounds like it's very straightforward.
With these singles, I mean, geez, it's just adding a scan, and you tell people about it, and they're like, "Oh, that's it. Like, that's all we got to do." And then the lab gets it, and they're like, because it's very interesting when you look at it cross-sectionally on a lab side, and this is where we got the idea of the research project is. You look at what you scanned on the soft tissue, and it's collapsed. Then you put the provisional and merge that back in, and you can see cross-sectionally, provisional's coming here, tissue's here, and you can measure the difference. And so from the lab side, they can go ahead and copy that exactly. So that, I mean, it's like NASCAR, you just unscrew the one, pow, pow, take the one out, put the other one out. You get no blanching, no anything like that.
Well, and think of the time,
exactly the same.
and the time savings on that is massive. Rather than taking that out and bringing it in the lab and pouring the putty matrix and GC pattern resin and all of this work that you go through to create this customized impression coping, it's one scan, it's 30 seconds of your life, basically.
I think one of the things too is, like, a lot of times we may not have the ability, John, to go to immediate loading per se. And we have this beautifully designed custom tissue former. This can work in that as well, because there's some type of geometry in situ that could be indexed per se digitally, whether you have dimples or some type of, definitive way to merge, right? And then you scan that on the actual analog, right, outside of the mouth. Well, now you have all your critical contours.
Right.
And here we go again, the same thing. And then you can order the provisional, right, and then go from there. And that exact contour.
Yeah. So I think that's, as you said, seems like singles, we've pretty much got it buttoned up pretty well. Talking about, let's expand it to full arch. Let's, you mentioned, you kind of touched just briefly on some of the things that are maybe limiting us from being able to go completely just, no changes necessary, because there's always biology that gets in the way. But let's talk about what we can do.
Sure.
What can we, and I know we've talked about this before on the podcast, but it's always changing. We're always getting new things happening with new technology, new software. How far are we pushing this in terms of being able to go to the full arch, say definitive prosthetic in the digital world? Where are we with that?
So, it's funny because when we talk about full arch, digital restorations, like what we need to do, all of a sudden, all of us kind of step back and go, how do we do this? But you've got to realize, like, analog, digital, it's just the tasks like that you need to do. Like, you need to, one, figure out your occlusion in your video. That's task one. Secondarily, you need some sort of template to help us know where teeth go. And then task three is registering the position of the implant or the abutments, depending upon which route you're going for full arch relative to the tissue. Like, those are the three tasks. And again, those tasks, we apply them either in with digital tools, physical tools, analog tools, whatever. Okay, so we're trying to do the exact same things. And so what we can do with digital is, again, if you've already got this patient in this conversion prosthesis, okay, we always have this thought of like, well, we've got to start over. We've got to make this brand new thing and try this in. Well, the way I like to look at it, that crappy conversion that you did, treat that just like a terrible aesthetic trying of a denture. Right. Okay. If you've got this terrible aesthetic trying of the denture, you're going to say, okay, I missed the midline by 9 feet. So move it this way. I canted it, like make all these changes because that's what it is.
At least it's first trying.
Right. You're trying.
You have a reference point.
Yeah. And so that way, when it gets in the software, you can go ahead and put it in. You can tweak things and like, next visit, we're good to go.
Right.
I mean, so there's been a number of these lately that I've been doing where literally I have one visit for the scans and everything like that. The next visit, I'm delivering the final because I'm just saying, look, here's what we have. These are the tweaks which we need to make. Go for it.
Yeah.
Right.
Yeah.
So because why not? We do the same exact things from the analog world with dentures. We're like, okay, your aesthetic trying was off, but we're going to make these changes. Go ahead and make those changes, process it. But then all of a sudden from this side, we're like, whoa, I've got to just move it over a little bit here and here, but let's do a try-in first. And there's nothing wrong with doing a try-in. There's nothing wrong if you want to do a digitalog type format where you're doing all digital and snapping an impression for a model in case your lab wants that. There's nothing wrong with doing these things.
But this is saving you time. So two questions that commonly come up, right? And these to you are softball questions because you deal with it all the time. What if you want to do another try-in? How are you doing that? Are you printing it? Are you doing this in acrylic? We'll talk about that. And then secondly, most people kind of don't even get to this point. They go, can I even scan the implants? Is it accurate enough to do a splinted restoration, as a definitive without a verification jig, right? So I know the dreaded, we have to talk about it. I know. But first let's just get, that's right. Get in your happy place and just try to just hang with it. Cause I know that's a tough one. What about the try-ins though? Like if you do have to do a try-in and you start with the crappy conversion prosthetic and you're off by several millimeters or you're not sure about tooth size and shape, how are you approaching that in terms of what materials are you using for that?
So usually the materials that we do on that is, again, we're doing this all digitally. So you've got two options. One is a printed try-in and one's a milled try-in, okay? If you'd asked me this question 2-3 years ago, I would have said 100% milled. Okay. Asking me this question now, I'm saying nearly probably 90-something% printed. Okay.
That's a big change. It's a big change.
Yeah. Because from an economic standpoint, we can print things so cheap.
That's right.
So cheap. Okay. And again, you do have some issues sometimes with printing because, again, you've got the supports and whatnot, which you need to take out. The camming, if you will, of nesting it into the plate. You can have some issues that way as well. But for the most part, we're printing all of that, okay, and doing our try-ins that way. Our finals, again, I'm still a big zirconia guy. I know Will Martin's giving a lecture on this tomorrow, about the future of restorative. So we've talked a lot about this, but right at the moment, I still like zirconia.
Yeah.
So with Zirc, we're milling Zirc to basically full contour, and then all of the final characterization of pink and different stuff like that we're doing with Mio porcelains because you can make those suckers look so beautiful.
That's right. Facial cutbacks.
Yeah.
Right.
Well, and again, it's almost not even a facial cutback.
Yeah, just staining.
It is straight up
staining
because it's as thin.
Right.
Mio, you can put as thin as stain, but it's actual porcelain.
Right.
So you can do all sorts of characterization with these things. So that's what we're doing
for
now.
the try-in stages.
The try-ins are going to be printed.
So the dreaded verification jig. Do we need it? Can we stay with that? I mean, how do you view that?
If you ask me the last time I did a verification jig, I can't remember.
Whoa.
Okay. Because
I don't like you right now, Mark. I don't like you.
What are you trying to, when you How many times have you been off on your verification jig that you didn't think you were off on your impression? Like usually the only times you'll do a verification is you're like, I don't know if I got that. I think it moved.
Right.
I'm going to do a verification.
Especially if you're doing verified impressions, right?
Right.
Which is a verification jig
When you're
in an impression.
splinting
When you're
and-
splitting multi-bases.
Yeah.
So again, I'm just not a fan of those, especially when we go digital, because, you know, and my lab folks and I have talked a lot about this because, again, if you're going digital, what do you verify? Like the whole point of a verification jig by definition is to verify that the model is correct, that there wasn't distortion.
So
in your
you feel
impressions.
like that we're accurate right now with scanning, intraoral scanning technology,
I do.
right?
Yeah.
Enough to be able to mill in zirc, titanium, chromium cobalt.
Yeah.
We can do that.
I do. Yeah. Completely.
With any scanner?
That's where it gets a little more difficult because, you know, unfortunately, all scanners aren't created equal. I mean, I'll just be honest about that, especially when it comes to soft tissue tracking and different things like that. I'll be like, most scanners have gotten pretty darn good at doing teeth and getting cross-arch trueness on teeth. We've got a paper that will be coming out that we just finished where, you know, everything was, when we look at cross-arch, and this also had orthodontic brackets on there. So again, it's shining weird and doing different stuff like that. And I mean, everything was basically between like 30 microns up to 50 microns cross arch, which was awesome.
That's pretty good.
You know, and again, that's with teeth. And again, we've seen other trials that we've done where we've gotten down to almost, with one particular scanner, we've gotten down to 9 to 10 microns cross
Amazing.
arch, which is
Amazing.
freaking crazy.
Yeah.
So, and when you look at misfit, and again, we don't really have a lot of good data on misfit of bars and misfit of full arch prosthesis either. The only real paper there is there's one, and again, I don't remember the name of the individual, but basically showed that, you know, at 100 microns of misfit, the bar was still passive.
That's right.
It wasn't until you got up to about the 170 to the 210 micron range where that's when
That you
things
could perceive
started
it.
to, you know,
Yeah.
because like you put it in here, then you like have to shim this side up, and you're
Yeah.
like, it's going in, but
Yeah.
not real. You know?
The one screw test doesn't really work
Yeah,
in
it
that
doesn't.
situation.
No. So that, you know, until we get better definitions, and again, this is another project which we've wanted to do, we just haven't had time, is to really get kind of a blinded thing where we get multiple people. We've got, and we've taken so many scans of things, we know ones that are off X amount due to different scanners, and so we're going to build bars of each of those with increments of 50 microns off and see at what threshold us as clinicians go, nope, that's off.
Right.
Because we don't have that data really.
Well, to close out the show, I think the next thing is not every patient can, one, afford a fixed prosthetic. Some people need lip support from a prosthetic that, you know, is removable.
Yeah.
And some people aren't candidates for dental implants for whatever reason, and therefore they have a removable conventional denture.
Right.
And you mentioned at the beginning of the show today that you're no longer doing conventional denture prosthetics. You're printing or you're fabricating using 3D technology your dentures. Now, the questions I have about that I think I'd like for you to highlight for John and I and our listeners is, where's the functional tissue molding coming from? Is there still a reline prosthetic, a process, a system that at the end here we are doing a wash?
Yeah.
You know, go ahead and share about that.
I think we've got this big misnomer when we think about digital dentures or digital anything. It's like it's all 100% digital. The great thing about digital dentures is it's digital manufacturing. Okay. So what we've been doing is we've been keeping our same clinical visits. Well, we've been changing those a little bit too, but again, it's in essence the normal clinical visits that you always do, you know, initial impression, custom tray, wax rip. And then we get to that point, and then that's when we jump over to digital.
Gotcha.
Okay, for the manufacturing part. So we do our try-ins are all digital try-ins, you know, and if we're doing both arches, we'll lute the upper teeth, the lower teeth we won't lute, so it can just sit in there. That way, again, at a school perspective, they're not the greatest, I'll be honest, at JRR, you know, of getting the right vertical and getting the bite and things of that nature. And so that's why we don't lute the lower teeth, because if we need to, we just cut off the posterior parts of the teeth. That way we can see where those front teeth are relative to the, you know, the lip line. And then we can go ahead and put the bite registration in the back, rekey them back in case we need to make a new one. And so that's been a wonderful thing, because we've actually, when they're on and it's the aesthetic try-in, all we do is run it in the back, polish them up, put them in, and the patient leaves.
Yeah.
Mm.
And
So you don't
are
have
these
that extra.
milled bases or printed?
These are printed bases.
Printed bases.
Printed. Now
Yep.
that's interesting because for for years it was the milling that was beating it and as far as trueness to that master model. But now with some of the printers I'm seeing out there out of California, right? Silicon Valley, yeah, kind of a cool startup. And
yeah, they got some nice stuff.
Yeah, I'll say the name, right? Carbon printing, right?
Yeah, carbon's been a big one.
Carbon's been a big one. Our lab uses carbon printing, and they're doing digital basis now, and I've been dabbling with that.
Yeah.
So the strength and the fit of printing, do you feel like is rivaling milled at this
I
point?
do. Yeah. I mean, I'm a huge milled fan. Huge. Okay. That's what I helped Ivoclar with their stuff years ago, and I love those things. Okay. And it's just recently that we have been getting into the
And
printed.
is the economics of that driving that from a school perspective too? It
is.
has to, because I would think, because you still have paying patients, quote unquote, or patients that aren't paying, and you have to be able to do these things rapidly and economically. I would think that plays a huge role.
It does. I mean, when we looked at the costs and what we were getting from our lab, is like they were expensive and they just weren't very good.
Yeah, it takes to process denture bases with like maybe an Ivocap process, whatever, injected molding, let's call it that.
Yeah.
It's very technique sensitive.
Yeah.
It requires a very high level, and as labs are consolidating now, we're seeing so many labs just even die off in the last year and a half. And what's good about that is that there's there's larger labs that can afford to purchase some of this technology and apply some of the thinking that we have with conventional prosthetics. Yeah. The next thing I would say as we finish on this last topic is, I just gotta ask.
It's hard to finish. Yeah,
this is the problem.
Right after
the problem is that the teeth, the shape, and the mold, and the look, and how durable they are, and how we're putting those in the actual printed base.
Yeah.
Some of it's glued, some of it's got some kind of mechanism to hold it in mechanically. It speak to the aesthetics and how are these holding up?
Yeah, how are they? That was our initial concern, because I saw some printed bases that we had fracture issues, we had tooth dislodgements. Are you seeing those issues?
Yeah. So again, some of that has to do with the types of resins that were probably used. The newer resins, like the Lucitone print, the Flexera base, Flexera Smile for the teeth. These are much, much stronger materials than the old Dentka that we used to use. And again, I used to always hate that one because it would be translucent. You could see the necks of the teeth. I loathed printed dentures forever.
Yeah. They weren't pretty at all.
They looked terrible.
Oh, they looked awful.
Yeah.
They were like worse than the economy dentures.
Yeah,
that's right.
Yeah.
That's right.
But now with these newer materials that have been released, it's just like anything. Digital is just a tool. You can make it as good or as crappy as you want it to be. Okay. And some of that, it's been great because with the dentures we were getting made from the lab, they were using the cheapest, crappiest, most economical teeth they could. Now, again, we're using all Phoneris molds. We're using blue line molds, using these great molds. And then again, we just have to do a little bit of finishing, put them together, and how you generally fuse these together is you actually use the true resin that it's printed out of, and you put them together.
So you get a chemical cure.
You do.
Right.
Yeah,
Not just mechanical.
Yeah, so it goes down, obviously, into the socket, and then you also get the chemical cure, because you take them both out of printers, you clean them up a little bit, you put the material in, put them together, then you go ahead and cure everything at once.
Wow.
And they're holding up.
Yeah,
obviously.
Well, again, we've only been doing this for a couple months.
It's still early, because these materials are, they're only a year or so, 2 years old now?
Yeah, a couple years old.
So, we don't have a lot of data.
Right.
But so far, I guess.
So far, everything's been great. It's funny because even our students are like, holy crap, these look so much better. And seeing the faculty, at first, everyone's like, you're going to do those in-house? Like, these suck, because that's what we've seen.
Yeah.
Right. And then all of our faculty's like, holy crap, this is way better than any denture I've seen come through. And again, part of that is you've got to put that effort into the design to make it that way.
That's right.
And then all digital isn't just hit a button. Like, you've got to then get it out, and you've got to do a little bit of finishing work. And that's what's fun about it.
Yeah. So that, I think, is the link, John, is that there is still some finesse in this.
Yeah.
Oh yeah.
There's artistry.
Right. There's
Absolutely.
artistry. I think there's benchtop work that really doesn't really show up on the Instagram world when it comes to this stuff. And
you just see the end result.
You just see the end result.
Yeah.
And so that's what I like about Mark. He brings a realism to the show. and to the topics that we're talking about when it comes to this digital, because there's so many people showing that, hey, look at this beginning, look at this end, and I did it digitally.
Right.
And I scanned it and all these things. But what really goes into that, right, is still the technical parts, understanding the know-how. There's still the steps in the process that must take place.
Totally.
And the knowledge, right?
Yep.
And I really appreciate you coming on and
Yeah.
talking about these things.
Yeah, it's been fun, always fun. Like we said earlier, I mean, the conversation could continue for hours because it's always good stuff.
It always does.
And it always does work that
we
way.
go, right?
And and congratulations once again, being on the podium, it's awesome to see
Thanks.
how things are moving, and obviously things are happening at University of Utah, and we're excited to see kind of what the future brings with that as well. It's going to be fun to watch. I'm sure we'll be seeing you over the years on the show, hopefully many, many more times.
Thank you, Mark.
I
thanks.
appreciate it. Thanks, guys, for having me. I mean, it's fun as always. So
Yeah, absolutely. Well, once again, if you have enjoyed what's happening here, shoot us some info. Tell us what you like. Tell us what questions you want us to ask. We've got our schedule up for the rest of the day. We've got some high-level speakers once again coming up as we proceed through the day. It's going to be kind of nonstop today, Wes. It's going to be one after another of some really great content. So we're looking forward to bringing more of that to you as we cover the AO annual meeting. For Mark, for Wes, I'm John, and this has been a broadcast of The Dental Guys.